All right, so we'll move on to Dr. Houten. So Dr. Houten joined the department very recently, over the last few months. He, prior to joining Mount Sinai, completed his training at NYU, followed by an combined orthopedic and neurosurgical spine fellowship at NYU after residency. He spent about 10 years, or a little more than 10 years, at Monty, where he became the chief of the division of spine surgery and grew the division and volume there significantly, performing artificial disc replacements and a wide variety of minimally invasive spine surgeries, as well as pursuing research in that area. After a brief foray to South Florida, he then relocated back to New York, joined the faculty at Northwell at Maimonides Medical Center prior to then coming in and joining us. Everywhere he's been, he has innovated and grown programs, and we hope that he will continue to do the same here. And he'll be speaking to us today about his experience in minimally invasive spine surgery. So thank you, Dr. Houten.
Just trying to get my screen shared. Can you see my screen?
Yes, we can.
Okay, great. Well, thank you very much for this opportunity to present on the topic of image-guided spinal surgery, which is a passion of my career, and also for this opportunity to introduce myself to the Mount Sinai neurosurgical community. As the residents have heard on many occasions, you never stop learning as a neurosurgeon, and as you go through your career, you'll find that nuances are appreciated and practices change. And with the image-guided spinal surgery, this is an area that I think developed almost entirely during my time with neurosurgery, and I have some personal perspectives on how that affected my practice that I'd like to share. I have no disclosures. So to state the very obvious, spinal anatomy is complex. I chose to show the upper cervical area, which arguably is the most complex portion of the spine, and surgery requires precision. Fixation may endanger the vertebral artery if the trajectory is a few millimeters too lateral, or endanger the spinal cord if the trajectory is a few degrees too medial. But when you do your exposure posteriorly, you get the image in the lower right corner of the screen. You see the bone surface, but the vital structures like the spinal cord and the vertebral artery are deep and hidden from view. Perhaps also to state the obvious, a lateral X-ray or a lateral fluoroscopic image does not tell the whole story. This particular case was one that I saw that had been done at one of the very most prestigious institutions in Manhattan across town. The lateral fluoroscopy image in the OR, which I read the op report, showed that all the pedicle screws were in good position, as indeed they are appearing on this lateral X-ray, but yet there is a major problem with malposition. The history of spinal instrumentation is really a separate topic from image guidance, but they do intertwine with one another to a certain degree. And I need to provide a little background information to explain the milieu in which image-guided technologies developed. The first major spinal implant was the Harrington rod. And the key point is that this really did not require image guidance because it took advantage of surface anatomy. There was an upgoing hook and a downgoing hook that went under the lamina. It was fairly effective at correcting the scoliosis deformities in the coronal plane, not that successful in addressing the sagittal plane. And some other shortcomings were that because it was not segmental fixation, it just pushed up and pushed down, it had little rotational stability and required external bracing. This is a RISR table, which is a table designed to exert forces on the body to hold the spine in a certain position so that external bracing could be properly fitted. In many respects, spinal instrumentation took a further leap forward with the work of Eduardo Lucchi than that of Harrington. And on the top is the Lucchi rod, which I still see on occasion in an older patient who has had surgery many, many years ago. Lucchi's problem was that he practiced in Mexico, and the summer is pretty hot and humid, and patients who had to wear a very restrictive body brace did not, after having Harrington rod correction, were not very tolerant of the brace. And Lucchi had to come up with a way that he would be able to better treat his patients without bracing. So he came up with a different technique, which was a revolution in that it was segmental fixation, meaning that the device was fixed to every level of the spine. It's sort of hard to understand just glancing at the left portion of the screen, but what this is showing is that Lucchi took wires, bent them over, and then the bent end would be slipped under the lamina, both on the left and the right. Then a twisting and crimping tool was used to twist and twist the wire to a Lucchi rod until the spine was pulled to the rod and became straight. And the fixation was actually quite powerful. This is Dennis Drummond, with whom I identified because he was worried about complications. He developed an alternative method to the Lucchi fusion using wiring that was not sublaminar, which he was worried might injure the spinal cord or cause dural tears. So by piercing through the base of the spinous process, he would thread a wire that was then attached to a Lucchi rod. And I was told when this procedure was popular, it was known as the chicken Lucchi. Pedicle fixation, as we are more familiar with today, traces back to the work of Roy Camille. Roy Camille was a French spinal surgeon, and he published two papers, one in 1969 and one in 1970, that described the technique for placing pedicle screws into the lumbar spine. There really was a considerable delay in this becoming popular in the United States. And you first see a number of papers in the American literature only in the mid-1980s. Here's a paper describing interpeduncular screw fixation. I guess they hadn't settled on how they were going to call the procedure. Part of the concern was the fact that Roy Camille's technique required placing a screw deep into the spine without any direct visualization. For the thoracic spine, putting thoracic pedicle screws involves a bump up in the level of potential risk. And the residents might be shocked to hear that during my residency in the 90s, I never saw a thoracic pedicle screw. Instead, what we used were hooks. The usual technique for the upper end of a construct was that we would put a downgoing hook over the lamina that was the terminus of the fixation. This skips a level, but usually the level immediately below, an upgoing hook is placed, and then we would compress together to create a claw. And this actually was quite a strong fixation. I continued to use hooks well into my practice as an attending in the mid-90s. And the truth is, I never remember having a case where they failed or having a patient have an injury from the hooks. So although they've sort of disappeared now that thoracic pedicle screws are well established as a practice, I think there is an importance to recognizing the development of surgical technique. And one of the reasons is that old ideas sometimes come back. Right now, the spine surgery world is struggling with a problem called PJK, proximal junctional kyphosis. You do a fusion from T2 to the sacrum, and you find out few months after the surgery that the pedicle screw at T2 has lost fixation, or that at T1-2 that some kyphotic deformity is developed. And there are many investigators who are wondering, maybe we should not do such a rigid form of fixation at the proximal end. We should do something called a soft landing by using downgoing hooks. So when I did my residency at NYU, this is what spine surgery looked like. It was not minimally invasive, to say the least. What we called image guidance was getting a lateral X-ray after putting Kirschner wires into the pedicles and then getting a lateral X-ray to see what direction the wires were with respect to the sagittal plane. And the personalities that trained me helped influence how I viewed spinal surgery. And I'd like to discuss a few of the formative experiences that I had that influenced my development as a surgeon. When I was a medical student, the chairman was Joseph Ransohoff, and the first neurosurgical operation that I ever saw in the operating room as a medical student was a procedure that he did, and I would go on rounds with him. Although I did not have a long period with Dr. Ransohoff, he did say something that I realized years later made an impression upon me. When I was trying to adopt image-guided technologies to use in spine surgery, I will tell you that there was a time when image guidance was not really held in very high esteem in the spinal world. People said, it takes too long, it's too fiddlesome, why do you need a computer to tell you where the spinal anatomy is? And what it was that Dr. Ransohoff told me was that if you are doing something that you know is good for the patient, you should not be listening to what other people are saying. Now, of course, I'm taking his quote wildly out of context. I think at the time he was savagely beating a resident for not knowing what the dilantin level was. But at least I remember the good part that came out. On the right is Fred Epstein, who I think had a more significant influence upon me. I did my first research paper with Fred on intramedullary spinal cord tumors in patients under the age of 3. And he bought me the loops that I still use today. And what made an impression upon me was how interested he was in using technology. When he did a case, let's say an intermedullary spinal cord tumor, you were guaranteed to have more people and equipment in the room than just about any other type of case. Ultrasound, the microscope, of course, monitoring, which he was a big proponent of and was not uniformly used at the time. And he also experimented with using the CO2 laser. I think my more mature development as a resident came from my chairman, Pat Kelly. Pat Kelly was not a spine surgeon. He was a brain tumor and functional neurosurgeon. He was interested in stereotaxis. Here is his proprietary system, which looks enormous, and probably with the computing power it had, it could fit on a watch today. But what impressed me was the interest in finding a way to do a smaller, more precise surgery, localizing exactly where the incision needed to be, making a bony opening exactly the size that it needed to be in order to accomplish the goals of the surgery. And what I was thinking about was, wow, these cranial surgeons were so far ahead of where the spinal surgeons seemed to be at the time. And here I was operating with Dr. Kelly. This is probably about 2000. Little did he know at the time that my mind was on all of these wonderful new devices and implants that had become available for spine. This is a slide that probably has nothing whatsoever to do with the talk, but I should mention that I did residency together with Dr. Coppell, who was just behind me in the residency, and he looked as cool and as hip in those days as he does today. Now, there was, toward the end of my residency, an initial foray into trying to use image guidance in spine. And FluoroNav was an early system which utilized fluoroscopy to navigate. And it was primitive. You took an AP and lateral fluoroscopic image, you had a fiducial system, and then you navigated the static fluoro image. But even as primitive as it is, it had all the elements of a modern navigation system in that it had light camera, a patient tracker, and some fiducial system to be able to give a coordinate system. While preparing the talk, I realized that if you want a FluoroNav, you can get them cheap on eBay. And so you could put it downstairs in the basement next to your ping pong table. So the next generation of image-guided systems for spine involved using a preoperative CT and then registering it to the visible spinal anatomy once you have done the exposure in the operating room. And this really was a major advance because it, for the first time, gave the surgeon the all-important axial view that you see on a CT, where you would be able to see where the medial wall of the pedicle was with respect to the canal. The system needed paired point matching, which is that you would pick on the workstation a point that you thought that you would be able to detect and see after you've done the exposure, and then point the tip of an instrument to that point and then match those two to create your registration. I'm sorry that I was not able to get a better picture with his face. This is Dr. Rumpapant. When I was working with him together, this was probably 2004. So I felt that these pre-op CT-based systems had a lot of problems. Number one, matching of the points on the screen and what you see in the patient wasn't as easy as it always seemed. Also, there was a concern that there could be a change in the position of the spine with regard to the supine position that the scan was acquired in, because the patient's lying on their back on the CT scanner, and then the prone position of the operation. And I think that this is the stage of image guidance that a lot of people were turned off to navigation, because the registration process was lengthy, it was cumbersome, and many people did not think that it was worth the bother. What about minimally invasive spinal surgery? MIS was becoming popular in the exact same time frame, the early 2000s. And when you perform minimally invasive surgery through a tube, you really don't have surface anatomy exposed that can be used for registration. So essentially, the two technologies, MIS and image guidance, seem to be not compatible. So my first 8 years of practice, as much as I wanted to do image-guided surgery, my surgeries were MIS using fluoroscopy guidance. Fluoro has a lot of shortcomings. Obviously, it doesn't provide the axial view of the CT scan. The image quality can be poor in an obese patient or those who have a lot of osteoporosis and rarefaction of the bone. I, for one, am not crazy about wearing a heavy lead gown. And if you're doing these cases every day, there was a worry about what the cumulative effects of radiation might be. So this was a point of entry for another step in the development of image guidance. This is the forerunner of today's Zeem system. It was called the Arcadis Orbic 3D. It basically is an isocentric fluoro machine that would take a 360 or 180 degree image acquisition, and it created what looks like a poor man's CAT scan. And the advance that this device had that I felt was the significant step was automatic registration, meaning no paired point matching. You just had to get the scan and you would be able to navigate off of it. The problem was the image quality was really quite poor. It had a very narrow or small range of visualization. You could get 1 or 2 levels in at the best. I did not like it after trying it. It turns out that at that point, about 2007, there was a major advance occurring not in the neurosurgical world, but in the world of dentistry. Dentists were using a relatively new technology, cone beam CT, to create 3D images of the jaw. And some smart dentists figured out that when they imaged the jaw, they were able to get actually quite beautiful images of the cervical spine. Some people who ultimately worked with Medtronic adapted cone beam CT technology to create a device to get intraoperative spinal imaging that could do automatic registration and provide a near CT quality image to navigate off of. I saw this at about 2008. It wasn't really available yet, but I knew that this had to be a major move and change in the spine world. I went to the administration at Montefiore, where I was working at the time, and I said that this is a device that we have to get as soon as possible. They wanted to know how much it costs. I told them it's about $1 million, and they were not enthusiastic about it. So about 1.5 years passed, and the circumstances under which it came weren't the best. There was an orthopedic spine surgeon who really was quite excellent, who had an unfortunate case where he put pedicle screws in the lumbar spine. The patient woke up with severe leg pain and a foot drop. So they rushed the patient to CT. It showed that there was a pedicle screw malposition. So they rushed back to the OR. They spent many, many hours in the OR. I can only assume that it was a very difficult anatomy. And the patient came out still no better. Another CT was done. The pedicle screws were changed in position, but still malpositioned in a different way. And they had to go back to the OR a third time. Right after this, I got called to the administration suite, and they wanted to know the information about the O-arm. And 3 weeks after that, we had the machine in our OR. I believe that I was the first person in the tri-state area to use this device to navigate spinal screws. There was one system that was in the tri-state area that some surgeons were using to check the screws after surgery. And the other unit was at Memorial Sloan Kettering, and it was being used for prostatic seed placement. So I gathered the initial cases and compared them with similar cases that had been done using the AP and lateral fluoroscopic technique. And as I had expected, the data showed that image guidance provided superior accuracy. One of the things in particular I noticed right away was that it was easier to judge how long the pedicle screw needed to be. If you look at a lateral fluoro image, if the screw is going all the way to the deep edge of the vertebral body, it's already poking through the bone because the vertebra is curved on its front aspect. So sometimes I would have some anterior perforations using fluoro, depending on the angle that the screw needed to come in, especially at L5. But that never happens when you use image guidance. The first few years that I had the O-arm, I tried to explore all different kinds of applications where it might be employed to help patients. This was a case of an 18-year-old Hasidic boy who had a very complicated pelvis fracture, sacral fracture, after being hit by a car. If you've ever seen an open sacral fixation, it's one of the most bloody, ugly operations you'll ever see because it's hard anatomy to expose. This is made for percutaneous surgery. I was able to use a navigated pedicle probe and a navigated tap. There were no screws at that time available for this application, so I used long Synthes AO trauma screws. I think the upper cervical spine is an area that navigation can make a big difference. I've noticed a number of things that navigation can do much easier than doing surgery freehand. For example, when a C1-2 fusion is being done, I used to spend a lot of time coagulating the rich venous plexus that's between the arch of C1 and C2 to identify the starting point for a C1 lateral mass screw. With navigation, all of that time is avoided. You can point a probe exactly to the spot that you need to enter the lateral mass, and really no prep is necessary. I also think it saves tons of time when you're doing an occipital cervical fusion. When you put a plate on the occiput, I used to use a drill in 2 millimeter increments, going 2, 4, 6, 8, until I was through the cortex, not knowing how deep the cortex was at the point that the screw went through the hole of the plate. Now you can just point the probe to the hole and see exactly how many millimeters of bone you have and put the appropriate size screw in. This is an illustration of how the technology can be used for a bone of very diminutive dimensions. This was a fracture dislocation in a toddler. Although we try to avoid ionizing radiation for a child, in this particular case, the need for fixation was significant. I used, there was no pedicle screw small enough. These are lateral mass screws. Now, what about robotics? I used the Excelsius GPS robot for 3 years, and I have a little bit of a heretical view in that I am doubtful that robotics adds that much to spinal surgery. But what I think it does add is that it's another vehicle that navigation is used to be able to direct a surgery. And it turns out that I think the robot has been more enthusiastically adopted by our orthopedic surgery colleagues than neurosurgeons. And I think that the reason for this is that for many orthopedic spine surgeons, the robot is their first exposure to using navigation to place hardware in the spine, and they realize they like it. I only have a couple of slides left. This is another newer technology called Optical Topographic Imaging. Those who are residents probably know this better as the 7D. A preoperative CT is correlated with a surface map that's created from visible anatomy, and the camera is in the overhead light, which is a good position to be able to create a line of sight to the spine. And it has an advantage of not exposing the patient to radiation in the operating room. It has another advantage in that if the dreaded bumping of the patient tracker occurs, it's easy to recover from that by just getting another snap of visual anatomy. Still, there are shortcomings to the device. Number one is you need to have some visible anatomy in order to be able to create the surface map, so it limits the application for minimally invasive or percutaneous applications. There's another phenomenon that is discussed in the literature called geometric congruence, which or congruence, which the physics behind it is beyond my capabilities of understanding. But the point is that the shape of the spine in certain areas can create inaccuracies, particularly in the upper cervical spine, which is exactly where you need the accuracy the most. This is the arrow. It's not a cone beam CT, but it's a fan beam CT. It essentially gives you a conventional CT quality image and has a large field of view. It's become very popular. The shortcoming is that you need a specialized table. You can't use the regular Jackson table, and that is not particularly convenient for all surgical applications. This is a type of image guidance. It hasn't really caught on that much in the United States, but I am made to understand that it is actually quite popular in South Korea and in Japan. You send your CT scan to a company, and this is commercially available in the United States. They will make a 3D printed mold, which will be a guide. And let's say you're doing T12 to S1 pedicle screw to fixation. So you'll have a mold for T12, a mold for L1, and so forth. And you just place it on the spine, and you can drill your pilot holes and do your fixation. And this is my final point. Many people have asked, why is it that when you're doing the surgery, you're looking up at a screen and you're not looking at the patient? Shouldn't you be able to have a setup that you can see the anatomy, but yet at the same time be directing your attention to the operative field? And that is one of the things that augmented reality promises to be able to provide. You wear a augmented reality goggle, which can give you a heads-up display or a display that is superimposed upon the patient's back, and you can navigate in this fashion. There are actually 2 companies that have this technology, and it is in testing in various places in the United States. I don't think that it's quite yet ready for prime time. So in summary, technology allows for precise localization of deep structures, and I believe that it substantially improves patient safety. Thank you very much for your attention.
Thanks, John. That was wonderful. Very exciting, and many parallels to what we do up top. Comments from anyone? Jeremy?
That was a really great talk, I think, for the residents. I mean, I think we're constantly learning. Cal Post said on his last case at Sinai that he learned on that case. And I think every case you should aim to get better and learn. So I think anybody with decades of experience is a lot to glean from that wisdom. So I enjoyed that talk and watching your evolution over time. I think robotics, I agree with you today, but I think in 5 years, I'm going to disagree. I think they're constantly expanding and improving. And I think right now it's fancy navigation, but soon it'll be doing things maybe that we're not able to do as efficiently and smoothly yet.
Yeah, I just want to make a comment, John. It's really great to have you here in our department, bring your considerable experience, and you're of a similar vintage. I remember when Dr. Jenkins said stealth meant slowly touch everything and lose 2 hours. And thankfully, gotten better with image guidance, and happy to see us all work together to grow this place in general and also in image guidance. And thank you, Dr. Betterson, for giving us some of the latest tools, 7D and Aero and all the other things. And we'll have to keep that attention to keep up with others, with robotics and others. So thanks, everyone.
Hey, Dr. Houten, it's Alex Schuper, fourth-year resident. Thank you so much for the opportunity. It was a fantastic lecture. Nick Theodore actually came and visited us from Hopkins not too long ago, and an interesting conversation we had with him with the residents was, what do you think the downstream effect is on resident education in terms of maybe relying too heavily on image guidance, and does that take away from our surgical anatomy training? I'm just curious your perspective from a resident standpoint of how do you feel like this will affect our generation in the next, or sorry, our education, the next generation to come?
Yeah, it's a great question, and one that spine fellowship directors talk about. I think it does have a certain negative impact on resident experience. When you fumble through the anatomy, it can't be that great for the patient, but you do learn certain things that may make it easier if you're on that so-called desert island where you don't have the navigation. But I think on the other hand, you can't fight the tide of technology. People don't know how to write cursive anymore that well. But are people really that held back by not having good penmanship? Many people would argue that the tools and society has changed, and you want to be able to make the most impact. You have to use the tools that are being used now. I haven't published it, but I did an interesting study where I got some not sawbones, they're called true trainers. They're basically fake torsos with the spine inside them. And I had the residents on a Sunday get the O-arm and the OR set up. And I wanted to know what the learning curve was for putting pedicle screws in accurately, dependent upon resident PGY level. And shocker, the senior residents who had done hundreds of pedicle screw cases using navigation were no more accurate than the PGY2s, because once you have the technology, it's like the invention of the gun, that whether you're a strong guy or not such a strong guy, it's an equalizer. So it's a long answer to your question. I think the bottom line is that we have to try using the labs that we have, and either virtual or with cadavers, to learn the anatomy. And that, but in terms of what you're doing in the operating room, you have to be using the technology.
Thank you so much. Really enjoyed it.
Terrific. Well, I thought it was a great session today. We have a lot to learn going forward. I liked your comment about holding on to things you've learned throughout your career, because you may not know when you'll be called on to use them again. And that pertains to everyone's career. We've recently been talking about the resurrection of the microscopic transnasal pituitary, which is something that really has gone out of favor throughout the whole world. But I think that pendulum has swung too far in that direction. So many parallels. Terrific. Nice session. Is that it, Peter?
Yes. Yes. Thank you, everyone. Have a great day.
All right. Thanks.